Hi, I'm Cindy Owen. I'm from Memphis, Tennessee. Been a sonographer for about 30 years, and currently I work with GE Healthcare as a Global Luminary and Research Manager. My topic today is carotid tips and protocol. I'm going to talk about Carotid Doppler protocol and some tips for performing the exam. What I'm going to start with is the standardized protocol. That's very important that within each lab performing carotid Doppler that you have a protocol that is written down that can be followed by everyone in the laboratory. This will standardize the procedure and is very important for follow-up of patients. Because you want a patient who's coming back to have the exam done in the same way that it was done on the previous study, and that way it really makes sense for comparing from one time to another. So really everyone in the lab should be doing the study in exactly the same way, and the interpreters should also be using the same interpretive criteria when they're interpreting the study. So what should be included in your standardized protocol? Well, we'll start with Bmode imaging, sometimes referred to as 2D imaging or Grayscale imaging. All of those terms mean the same thing. I like to start with transverse imaging. I think transverse imaging is very important because when you are in cross-section, you can visualize the whole circumference of the vessel. This gives you a good idea about the plaque burden on the vessel. It's also a good way to look at where the plaque is located on the vessel so that you can plan your sagittal approach. You already have an idea of how much the lumen is compromised. It's also very helpful for differentiating between the internal and the external carotid artery, because in the transverse orientation you can often identify branches arising from the ECA, and that's one of the best ways to differentiate between these two vessels. So we're going to take Bmode images or transverse Bmode images of the common carotid, internal carotid, and external carotid arteries. And I may take more than one image to demonstrate different features of plaque that may be present, or take images from different projections. Once I've done the transverse images, then I'm going to turn the probe into a sagittal plane and take images in a sagittal plane, again, of the common carotid, starting at the very most proximal portion near the origin, and then up to the internal and the external. And again, taking images from different projections. This image on the bottom, the sagittal view of the internal carotid artery, you can see the plaque filling the bulb area, and that it has a heterogeneous nature and a very small residual lumen. On the right-hand side is the same vessel, but just from a different projection, and it just gives you a different look at the plaque. So it's important to look from multiple views. Now, as I mentioned, the transverse views can be used to help plan the sagittal plane. Take a look at this cine clip on the left-hand side. What you may have noticed when I started is that in the transverse orientation here, the vessels were diagonal to each other. And when you see a bifurcation that looks like that and you turn sagittal, you'll see the individual vessels, ECA and ICA, one at a time. What's important here is that you take the most inferior aspect of the probe, which is the most proximal part, the foot of the probe, and try to keep it steady over the distal common carotid artery. Then move the most distal portion of the probe, the top of the probe, that's cephalad, to the lateral for the internal and medial for the external. And it's kind of like a windshield wiper blade toggling back and forth between the internal and the external. This isn't a large motion, it's a very tiny motion because these vessels are actually quite close together, just going back and forth, and then making sure that each one of them ties back to the common carotid artery. Why is this important? Because it ensures that we're looking at two different vessels rather than one vessel from two different views. Which is a mistake we might make if we pick up the probe and simply move it between the vessels. It's easy to actually look at the same vessel and actually mislabel it as two different vessels. So this will keep you from making that mistake. Another thing you can do, though, to prove that you have both bifurcation vessels is to line up the bifurcation by rotating the probe on the neck so that the vessels are one on top of each other instead of side by side or diagonal. And watch as I do that on the right. I'm just rotating the probe until the vessels are lined one on top of the other. Now when I turn in a sagittal projection, you can see that I have a nice picture of the bifurcation. And so I'm showing the tuning fork bifurcation where I see both vessels at the same time. Is this necessary? No, obviously not. But it can be very helpful because it does prove that you've seen both vessels. Now, which vessel is on top, which is on bottom, that depends on your plane of approach. If I'm coming from a lateral or posterolateral approach, as in this case, which you can tell by the sternocleidomastoid muscle seen on top of the internal carotid artery, well then the internal carotid artery, which is the lateral or more posteriorly located vessel, will be the one that you see on top, with the external on the bottom. On the other hand, if when I changed my approach to line the vessels up one on top of the other, if I moved medial or more anterior, then I would likely have the external on the top because it is more anterior or medially located. Okay. Now, when we talk further about the standardized protocol, let's go into spectral Doppler. We want to make sure that we sample throughout the length of the vessels with our spectral Doppler. And in the common carotid artery, that means that we're sampling from proximal throughout the length. And we're going to take readings or images of Doppler samplings at proximal, mid, and distal CCA. ICA, again, proximal, mid, and distal. And in our lab, we actually include a further distal reading, just as far distal as we can. This really helps in those patients with fibromuscular dysplasia, which is seen in the mid to distal ICA. The ECA, we just take a single reading at the proximal ECA. Unless there is stenosis, in that case, I take at least 2 readings, one within the area of stenosis, the second further distal, to demonstrate the post-stenotic turbulence. And in the vertebral, the area we're most interested in is the origin, but it's okay to take a mid-vertebral segment and get a nice waveform. And then if we see turbulence, we'll look at the proximal segment where stenosis is most commonly located. And if it is abnormal with the bunny rabbit shaped waveform or reversed, then we also want to document the subclavian artery because that's where the stenosis would be. And the key there is to look at the proximal subclavian artery and not the mid to distal segment, because the part we want to sample is proximal to the takeoff of the vertebral, and that's what would be affecting the vertebral flow and causing it to be reversed. In these images that you see to the right, the one on the top shows the stenosis within the ICA, and the one on a normal ICA actually, and the one on the bottom is actually showing turbulent flow with the stenosis. Now, what happens when we document stenosis? How do we alternate or change our protocol in those cases? Well, whenever I have high velocities, I want to make sure that I have confidence in the velocity value that I'm getting. So I take 2 or 3 samples until I really have confidence that this is a reproducible velocity. At that point, I take a reading there, and then I'm going to move further distal, just a short distance, to document the post-stenotic turbulence. And you can see that in these images right here. The top image shows a nice clean spectral window because I'm within the jet of the stenosis. Below that, I have moved further distal, and now the window has been filled in with echoes, indicating that there is a lot of turbulence. This is in the area of post-stenotic turbulence, demonstrated by spectral broadening of this waveform. And you can even appreciate some reversed flow because of the swirling of the red blood cells beyond the area of the stenosis. So this is a typical waveform profile for post-stenotic turbulence. Now, when we're performing the exam, it's really important to pay attention to not only the Doppler, but also the Grayscale image. And for the Grayscale or Bmode image, we want to enhance our settings so that we can see low-level grayscale. One of the most common mistakes I see with new sonographers performing vascular exams is that they oftentimes want to make the image a very high contrast, and even sometimes take the TGC, time gain compensation, and decrease it across the vessel so that the inside of the vessel is really black, thinking that that's the best image they can make. But what you realize over time is that by doing that, you've really erased some real information and have decreased the likelihood of having the ability to display low-level grayscale or hypoechoic plaque, which can be very important plaque to display. So my recommendation is to use a dynamic range that is higher, that shows the shades of gray that you need. You want to be able to appreciate low-level grays. Choose a grayscale map that shows low-level grays. Have the overall gain high enough that you could perceive plaque and increase the TGC within the vessel enough that you're not eliminating any plaque that's present. And I'd rather have a few extra echoes in there that may be artifactual than to not see the plaque that's present. This is the point I'm trying to make. Look at this bifurcation. It's a nice image. But actually what's happened is the sonographer has used the TGC on the system to clean out the vessel and make it look nice and black inside. In so doing, they erased this plaque. Now, when I increase the TGC to show this plaque, yeah, there's some artifact over beyond it or proximal to it. I'm not really concerned about that. I'm more concerned about having the ability to demonstrate this pathology. So it's much better to have a few extra echoes in the vessel than to make it completely black, because that's artifactual. Here's another example. It looks like a beautiful vessel, but actually they have not set the TGC appropriately, and this low-level plaque is actually being missed. Now, there's a lot of advanced imaging features with high-end equipment that are available for us to use today, and these have been investigated over time and really proven to help improve the quality of our image, and should be used if you have these capabilities on your system, which most likely you do. One is harmonics, which helps us to improve the contrast resolution. There's compound imaging, which steers the beam in multiple directions at the anatomy of interest. It combines those different steerings into one displayed image. This gives us better boundary detection and closer to perpendicular incidence to multiple surfaces of a structure or a regular plaque. We apply speckle reducing algorithms now to the image to help reduce that salt and pepper look that we're so familiar with ultrasound, which is actually an artifact and sometimes obscures anatomy. And you can see that by layering these advanced imaging features, we steadily improve the quality of the ultrasound images. So for example, this is a pretty decent baseline image, but I think everyone would agree that it's a little bit better now, and now it's a little bit better, and then the final image is even the best. It's showing all of the boundary of that plaque and its internal composition, because we've actually layered harmonics, compound imaging, and speckle reduction. This is another example, the base image on the left, the improved image on the right after using the harmonics, compounding, and speckle reducing algorithms. So I would just encourage you to use these features on your equipment to really improve the quality of the images. Harmonics is particularly interesting because it can sometimes be used to actually visualize the flow. And if we see the flow with harmonics, it's even at a higher resolution than we can ever achieve with color Doppler or with power Doppler imaging, for example. So the image on the right that you see is not some new flow imaging technology. That's simply high-frequency harmonic imaging. And it was achieved by using the highest frequency that would actually penetrate, going into harmonics. I steered the beam to just towards the direction or into the direction of the flow, and then increased the gain within the vessel and decreased my frame averaging. And by kind of making some of these adjustments, I'm able to see the flow and really understand the hemodynamics that's occurring and appreciate how tiny this jet is and this tiny residual lumen on this very short segment stenosis. So sometimes understanding how to manipulate the controls on your particular ultrasound system can really make a difference in the image quality in certain pathological situations. Okay, back to our standardized protocol. Let's talk about taking the Doppler sampling in the common carotid artery. Remember, I said sample proximal, mid, and distal. But we want to use just one of those samplings to apply to the ICA-CCA ratio, which is part of our diagnostic criteria. And the sampling that we're going to do is the distal common carotid artery. Now, why do we care about this? We've been using the ICA-CCA ratio for years, but the problem was that there was no standardization about whether we used the proximal or the distal or the mid. And so when follow-up patients would come to the lab, they may have a different ratio, maybe 2 or it may be 4, and it's not due to progression or regression of disease. It was really due to which sonographer performed the study and where they obtained the CCA waveform. There's a study that was published down here in Radiology way back in 1999, and they found that the velocity within the common carotid artery is not uniform throughout its length. It's higher in the proximal segment and it's lower in the distal segment. So you can see that if you use different locations within the common carotid artery to obtain the sampling that's applied to the ratio, you will get different results. So we want to standardize it. Where should we standardize it? Probably not the proximal location, because it can be quite tortuous. The vessel can actually be quite mobile there sometimes because it's pulsatile, so it may be challenging. The mid segment, it's hard to know exactly what is meant by mid. A good way to standardize it is to go to the distal segment, about 2 centimeters proximal to the bifurcation. This is reproducible from time to time and very, very easily. Now, do I actually go and take the calipers and measure? No. We all have these scales on the screen, and I just kind of eyeball about what is 2 centimeters, and then I look and just eyeball about where 2 centimeters is proximal to the bifurcation, and that's where we're going to take our reading that's applied to the ratio reproducibly time after time as much as possible. Okay, differentiating between the internal and the external carotid artery. This is a key component of the exam, and actually something that can be quite challenging. And one of the ways that's been suggested to help in this process is to perform a temporal tap maneuver. And the temporal tap is a way that we actually auscultate the temporal artery just in front of the ear. You can feel the pulsation. And then while you're in the vessel that you think is the ECA, you would tap on it. And while doing so, you would appreciate these oscillations in the waveform. But unfortunately, that's really not that accurate. There was a study that was published in Radiology way back in 1996, and what they found is that there was the oscillations could actually be seen in the external and the internal carotid arteries in up to 1/3 of cases. And in fact, in about 1/3 of those, the oscillations were greater in the ICA versus the ECA, and present in the common carotid artery in over half of cases. So this is an unreliable way to differentiate between the internal and external. Just to follow up on that, here's a couple of cases. This is the internal carotid artery on the top, and you can see the temporal tap maneuver shows very prominent oscillations. So is it mislabeled? No. Let's look at the external carotid artery. It has the same oscillations. So what happens is that most of the time we already have a good idea that we're in the external, and we perform the temporal tap and we see the oscillations and we think it is confirming where we are. But in actuality, if we also did the same temporal tap maneuver while performing Doppler in the internal carotid artery, we would likely see the oscillations there as well. So how do we differentiate between the internal and the external? It's better to look at position. Internal is more posterolateral, external is more anterior medial. It's better to look at the waveforms. The internal is low resistant, the external is higher resistant, and look for branches. The internal gives off no branches in the neck, the external gives off multiple branches. The best way to look for ECA branches is a transverse sweep through the ECA. This is just another case in point. This is the internal carotid artery with oscillations in a different patient, and here's the ECA. So try these other methodologies for differentiating between the external and the internal rather than relying on the temporal tap is my suggestion. Now, we use colored Doppler in our studies as a roadmap. The colored Doppler itself is not diagnostic, but rather it's a roadmap to help us place the Doppler sample volume and help with our Doppler walk through the vessel so that we can quickly see areas of interest where we might want to further interrogate with the spectral Doppler. Such as you see here, this is a nice example of the carotid bifurcation, and as we're looking at the internal carotid artery, we see the color is not filling all the way to the posterior wall, and that's because there's some atherosclerotic plaquing there. But not until we get just a little bit beyond the bifurcation do we actually see a change in the color Doppler from a dark red into some focal aliasing. And this focal aliasing is telling me that there's a higher frequency shift at this point. Now, a higher frequency shift could be due to higher velocities, or it could be that we have a smaller angle of incidence. So I'm going to look at this and assess for any changes in angulation of the vessel, and clearly there's no change. The vessel is straight. So that means I have to have a higher velocity at this point, and indeed when we sample at that point we can see the velocity is about 190 centimeters per second. So we can use color Doppler in that way to help us. We could also use power Doppler, just looking at the anatomy of the residual lumen and using that to guide our Doppler sample volume, or B-flow, or other flow imaging tools. The point is that the flow imaging tools are very useful for us, and they can provide a roadmap for placement of the Doppler sample volume. This is an example of using the color Doppler. Here I'm in the vertebral artery, and it's an abnormal waveform with a very low velocity, only 6.2 centimeters per second. And you can see the waveform itself has a very delayed upstroke to peak systole. This is termed a tardus and parvus waveform. It's tardy to get to peak systole, and parvus, it's a small pulse. Well, whenever I see a waveform like this, I know that it's indicative of disease proximal to the point that I'm sampling. So I'll look proximal, and when I look at the proximal vertebral, there's actually no flow, but then with color Doppler, I can actually see inflow to the vertebral that's reconstituting it. Without color Doppler, this could be a very confusing picture because I would get no signal in this area, and then here I would get a mixture of antegrade and retrograde signals that could be very confusing. But as you can see with color Doppler, very quickly I can tell the story of what's happening, that this vertebral is occluded proximally and then reconstituted right at where it enters the spine. Now we want to walk the spectral Doppler through areas of stenosis to obtain the peak velocity. And what I mean by that is we're looking here with color at the area of the stenosis. I'm going to place my Doppler sample volume proximal to that point, and then in real time I'm going to move it slowly through the area of the stenosis, listening with my ear for the highest pitch sound and watching the waveform for the highest peak. And that's where my highest velocity is. I may do this 2 or 3 times until I'm satisfied that I've really obtained the peak velocity. Once I'm comfortable that I've obtained the peak or maximum velocity within that stenosis, I take a hard copy reading and document, and here's the peak velocity. It's nearly 400 centimeters per second in systole and well over 100 centimeters per second in diastole. This is just another nice example of walking the Doppler sample volume through an area of stenosis, but in this case, one of the things that I want to point out is the use of a larger sample volume. And this is something I want to talk about a little bit because a lot of times we have historic baggage that we've carried along with us from the person who taught us to do this study, and we don't really know why we're doing some of the things we're doing, but just that this is the way we were taught. And when I was first taught, I was taught to use a very small sample volume when performing Doppler exams. The reason was because we tried to evaluate small changes in the amount of spectral broadening. Well, now we know that that's not a very accurate way of performing or estimating the degree of stenosis. And in fact, with the linear array transducers that we have today, small changes in spectral broadening occur even in normal situations. So what's better is when we get into an area of stenosis is to open the sample volume up. Instead of using a 1 millimeter sample volume size, here I'm using a 3 millimeter sample volume size. This helps me a lot because if I'm looking at a residual lumen that has a diameter of only 1 millimeter and a breathing patient with cardiac pulsatility, and I have a 1 millimeter sample volume, I can't keep those locations matched in real time, and I'll just get pieces of the stenosis, and it will be very hard for me to get a good Doppler signal. On the other hand, in this very tough case, if I make the sample volume larger, it improves my chances of being able to obtain more than one waveform to improve my diagnostic confidence that I'm getting a real signal back from this area and something that's measurable and reproducible. So don't be afraid to open the Doppler sample volume. Use one that's larger than 1 millimeter for most of your carotid work, especially when you're in a tight stenosis. Now, there are times when you want to keep the sample volume very small, and an example would be a case of a dissection. One of the things we're trying to prove when we suspect that there is a carotid dissection or a dissection anywhere in the body is that we have two different waveform patterns and two different lumens, and we're not dealing with some kind of artifactual echo. So here I've made the sample volume very small, and I moved it from one lumen into the other, and I've actually changed my sweep speed so that I'm displaying 8 seconds worth of information rather than the typical 3 or 4 seconds worth of information. This gives me time to move the sample volume from one lumen to the other and document that indeed there is quite a difference in the waveform profiles between the lumens. That confirms that I have a dissection. The color Doppler here is showing me that there's two different lumens of flow in sagittal, and then also in transverse here, this real-time clip is showing you two different lumens of flow in the transverse orientation. And that's the other thing that we want to watch for in dissection, is to show that there are two different lumens that are clearly visualized in more than one imaging plane and with more than one flow imaging modality, such as color, Doppler, and then also Bmode imaging. Now, another important aspect of the carotid Doppler exam is comparing the waveforms between the right and left side, and especially for the common carotid artery. Here on the left side, we see a normal appearing carotid Doppler waveform. On the right-hand side on this patient, you can see it's higher resistance with an absence of end-diastolic flow. When there's a decreased end-diastolic flow on one side compared to the contralateral side, that tells me there's distal disease, or disease that is distal to the point where I'm sampling. Now, that could be an ICA occlusion, which is probably the most likely event, but it could also be that there is a stenosis that's intracranial, and the most likely location intracranial would be at the carotid siphon level. And in this particular case, it was just beyond the siphon, and we have this high-grade stenosis within the middle cerebral artery. Now, we won't see changes down at the common carotid from an intracranial stenosis unless the stenosis is at least 70% diameter reduced. And of course, this is much more than that. We can also appreciate these changes in the color Doppler waveforms. On the side of an occlusion, or a side where we have high resistance flow, we will actually see in the color Doppler very little end diastolic flow, and here you see some blue, and that's the reverse component. On the normal side, we see flow throughout the cardiac cycle because we have a low resistant waveform that shows flow throughout the cardiac cycle. So this is an ICA occlusion, and this is what we see with the grayscale imaging is a debris-filled vessel and an absence of color fill in this area. Now, another reason we might want to compare the right and left sides would be with proximal disease. And here we have on the left-hand side very low velocities, a tardus and parvus effect to the waveform. When you contrast that with the contralateral right side, we have high velocities, more normal upstroke to the right common carotid artery, and it's really quite different. Now you might be tempted to think that the right side has a stenosis because the velocity is so high, but in actuality this is just compensatory flow. The real pathology lies in this case on the left-hand side. Let's look further at this case, and if you look up into the internal carotid artery, you can see that the velocity is still low on the left compared to the right. There's an abnormal waveform on the left, whereas the right has a nice normal waveform. But look at how high the velocity is on the right. It's about 180 centimeters per second. Again, there is no stenosis on the right. This is compensatory flow. When we look at the vertebrals between sides, both have high velocity flow, no stenosis. This is compensatory flow. Now, I can determine this is not stenotic, number one, because I know that I have high-grade pathology on the left, which I'm going to demonstrate to you in just a moment, but also because there is an absence of any type of post-stenotic turbulence in these other vessels that would have to be used to help determine that we have a stenosis. When there's stenosis, we see a focal acceleration coupled with post-stenotic turbulence anywhere in the body. Focal acceleration coupled with post-stenotic turbulence. That's not the case with compensatory flow, and that's not the case in this situation. In fact, in this situation, what happened is we even have reverse flow in a branch of the external carotid artery, antegrade flow in the internal carotid artery. There's a high-grade stenosis at the origin of the left common carotid artery. That's the real culprit in this whole situation. And if you look at the angiogram, you can see the bifurcation is patent. There's no stenosis here, but if you notice that the ECA is not really filling, and that's because it has the retrograde flow that we've just documented here in this color Doppler image. Lastly, we want to make sure that we keep our mind on the study, paying close attention to the numbers that we're generating throughout the study. This can be challenging when we have tortuous vessels, as in this case. This is a patient with a coil, and as we Doppler sample around this, we're going to be using a variety of Doppler angles, and if we're not careful, we'll get quite a range of velocities. In fact, in this case, proximal to the region of the coil, I had a velocity that was about 70 centimeters per second. And then as I moved into the coil, all of a sudden the velocity jumped up to 112. This didn't really make sense to me because there's no stenosis, no narrowing. Actually, it was just an angle correction error. And when I lift off the probe or update the image, I could see that I had moved slightly, adjust the Doppler angle very carefully for the area that I'm in within this coil, and I have a good velocity. So it was really closer to 79 or 80 centimeters per second in this area, not 112. Now, as I came around the coil, continuing to sample, all of a sudden I get a velocity that's 48 centimeters per second. Again, this makes absolutely no sense. It's an angle correction error. Even though the image looks like the angle correction is accurate, it's not. You update the image, double check the location of your sample volume, angle correct to the walls as it curves around. It's challenging to do, but making sure that the velocity values make sense. And sure enough, when I do this, my velocity is 70 centimeters per second, and that's more accurate. So in reality, in this coil, my velocities ranged from about 70 to 80 centimeters per second, never from 70 to 112, just down to 48. That doesn't make any sense. So keeping your head in the study and making sure that the velocity values that you're generating throughout the study make sense is very important. We also want to make sure it's telling the right story, again, that everything is making sense beyond just taking Doppler samplings in tortuous vessels or coils. This is a case that was done by one of my students, and after she did the study, she asked me to help her because she was concerned that maybe she hadn't really told the entire correct story. And my first input to her just on this image, it looks like there is probably a high-grade stenosis, but there's too much aliasing. And if you look at the velocity scale, the numbers here are quite low, which means that the velocity scale and or PRF and velocity scale are two words for the same thing. the PRF is set too low. It needs to be raised so that we can really appreciate some of the flow without all of the aliasing. Next, when she sampled in the common carotid artery, it looked like it was a very high resistance waveform and low velocity. And it looks like the angle correction is good, but she's sampling in the middle of the vessel, but not in the middle of the flow. So I really feel like the sample location is not correct. It should be in the middle of the flow. And the image is so dark that I really can't appreciate whether or not there's plaque in this area, which there was. And then the highest velocity she got as she sampled through the internal carotid artery was 200 centimeters per second. This could be right, but I'm suspicious that the velocity is probably much higher than that because when I have such a low velocity common carotid artery with high resistant flow, I would expect an even higher velocity reading in the stenosis. And in fact, this area of stenosis looks to be much tighter than that. So we brought the patient back down to look again, and as suspected, when we looked at the highest velocity in the internal carotid artery, it's actually closer to 400 centimeters per second rather than 200, so nearly doubled. And part of that had to do with the sampling location. She had not walked the Doppler through the entire area. She was sampling actually just distal to the area of maximum stenosis. So by going back and forth and walking through there, I was able to pick out the highest velocity more accurately. And you can see here an angiogram that shows this very high-grade stenosis, consistent with the findings. With that, I think the last thing that I wanted to say is just to enjoy your work, and I'm recognizing the staff that I've worked with for years and years at Baptist Hospital and Baptist Medical Center just right outside of Memphis, Tennessee. Performing carotid Doppler is one, it's a very rewarding study. It's an important study, but close attention to detail is key to success and key to obtaining the proper diagnosis for our patients. Thank you very much.